Definitely, we are discussing this pertinent issue of healthcare with the Cabinet Secretary for Health, Mrs. Cecily Kariuki. And as you've heard from our big question tonight, we are asking you if you think that Kenya can achieve universal health coverage. And I'd like to start this discussion, Madam Waziri, by just asking you to do a brief appraisal, if I may call it that. You've been in office in the health docket for a year. What would you say in your own assessment has been your achievement as a Cabinet Secretary for Health so far, 1 year down the line?
Thank you, Dr. Massey. I have been in office for 10 months, 2 to go for me to actually confirm it's 1 year. Mm-hmm. I have not only led the technical team together with the counties in defining what UHC, universal health coverage for Kenya, will look like in terms of startup, which we are taking on a pilot phase, and then we are going up to scale. But have also been involved in, as you will recall, bringing in 100 Cuban doctors into the country who have continued to work with their colleagues in the sector. And have done some phenomenal work. Importantly, I have also gotten to a point of operationalization of the Health Act of the year 2017. I would also say I have, using the technical teams in office, also managed to bring in a clear understanding of how specialized training for this country is going to look like, wherein we have gotten a point of agreeing that we have to bring in the collegiate system of teaching our doctors or getting our specialized HR into the country so that we are able to bridge the gap that exists. That is just to mention but a few.
Okay. All right. And I will actually just dwell on some of the things that you have mentioned as some of your achievements. And I'd like to start with the issue of UHC. I know the discussion of UHC has sort of been vague, if I may call it that, because the understanding that many of us, many Kenyans have, is that with UHC, universal health coverage, it means that my hospital bill is paid. And one of the questions that I would like to pose to you, and has been posed by one of the viewers on Twitter, is that what are the defining principles of UHC? We know it's a tripartite approach to healthcare. So I'd like you to just tell us, what are these defining principles, and are we there with this?
Three things, or three pillars come into the definition of universal health care. One is access, wherein we are looking at expanding access of healthcare services to populations, especially the ones who are underserved or have not been reached. And number two principle, we are looking at quality as a parameter, wherein we are looking at improving the care that we give Kenyans in all the facilities, be it the private, the faith-based, or the public facilities. And number three, and most important, we are looking also at reducing the financial burden. Every year in Kenya today, we have 26% of the population at the risk of being pushed below the poverty line owing to health expenditure. Selling land and other assets, it's not unknown to us. Getting to the famous, now infamous Harambes to raise money for hospital bills or to be able to ferry bodies of people who die in hospitals is more usual for populations across the country. So the third most important pillar is the issue of financial protection, wherein the people who are likely to be pushed below the poverty line get to be supported, starting on the principles of equity, where the most vulnerable then become our main concern, even as we move to cover the rest of the population. So those three define universal health coverage.
So as probably many Kenyans would agree with me that this looks and feels more theoretical than actual on the ground. Is this the case?
Not really. It is not, and Kenya is not going to be the first country achieving UHC, as it were. But before we move to defining how the journey for Kenya will look like in terms of attaining UHC, I would want to encourage Kenyans to view UHC realization as a process. Is a process which starts as opposed to a destination where we have everything that you require, which is also, like Kenyans have not gotten it too right, free. It is the word The operating word is affordable as opposed to being free. And we have seen countries walk the journey, starting with the political commitment, i.e. what we already have in the country today, pushing the fiscal space somewhat, but also committing and aligning all the policies towards a realization of UHC. And we have seen examples like Cuba. We have learned from Cuba, where with limited resources and being locked off country, we know that very well. They were able to, with a political commitment, push the bar very far, and that the life expectancy is one of the best that you can get in the country today. We have also looked at a country like Thailand. When we first started conversing around UHC in this country, we were comparing notes with Thailand some 15 years ago. Today, healthcare in Thailand is one of the best models that you can borrow and see. We've also looked at closer home, countries such as Ethiopia and Rwanda. Again, lessons to pick. And so it is not a theoretical proposition. We have the right environment with the right ingredients, starting with His Excellency's, the President's commitment to ensure that by the year 2022, indeed the level of care, its affordability, its access is a reality. And I want to assure Kenyans that we are doing everything in our means to be able to ensure that that is realized. I must confess and commend the governors, the Council of Governors, realizing that health is devolved. I have enjoyed, in the period that I have leading my technical team, very cordial and collaborative relationship with the governors, because we do realize service delivery is in the facilities which are being managed and supervised by the governors themselves.
I'd like to take the examples that you've quoted of Cuba. Cuba has almost 27% of its GDP in health, compared to Kenya, where we are doing 3.5% or almost 4%, that is from the national government, and when you combine it with the county governments, then it's 7%. So if we are saying we are looking into Cuba and we look at what we are doing, are we really moving towards funding healthcare adequately as it may be?
Masa is the reason I started by saying UHC is the journey. Cuba did not start with that kind of investment in health. They started with whatever was available for them, but determined 1 year after the other, they continued expanding the fiscal space as the need was. And that is the same model you find in Thailand. Nobody starts with sufficient resources, as you realize resources are finite. But with the political commitment that we have currently, it's been committed that over time we are going to continue increasing finances into the healthcare sector. If you look at history, we have come from a level which was less than what you quote today, and we've continued to expand. I guess what we must do is to accelerate the speed of infusing further resources into the sector. And that is going to be happening because we have the commitment and the determination to do just that.
Okay. Still on Cuba, Thailand, or the countries that have sense of UHC, of universal health coverage, we know that primary health care, basic health care is really like the bottom of a pyramid, if you may look at that, where when your foundations in healthcare are set well with basic and primary healthcare being offered and being available to the populace, then it will have a little ask of the top tier system in the healthcare system. But what we are seeing currently in the country is sort of an inverted pyramid where all our resources are sort of being lumped onto the bigger facilities, the level 5. We are looking at, the managed equipment services. We are looking at CT scans that are being given. These are huge capital asks for the healthcare system, yet our basic healthcare system, the bottom of the pyramid, is still starved of resources. And resources here is not just the financial resources, but also the human capital, the human resources in order to support the healthcare system. And we're seeing a lot of issues around this where resources and a lot of controversies in these resources that are going into the high capital and into the bigger facilities in the healthcare space. So how are we going then to start this journey of UHC if our resources are telling us otherwise?
In the next conversation that I'll be having with you, I will say one of my biggest achievements in the period I've been in office is actually convincing my colleagues and indeed the sector that we have to invert the pyramid. And we have, in terms of approach, the approach that we'll be taking towards realization of UHC is ensuring that the investment remains at the very basic level, the primary healthcare level, the community level. And that is the approach that we'll be taking. And there's common understanding. And I must again say, I have gotten a lot of reception even from the governors who have even domesticated the community health strategy, which has remained a policy at the ministry. And that is the approach that we'll be taking, so that then we actually focus at the lower level. Important element of that is that we will be looking and retraining and bringing in more community health workers into the sector, so that then basic issues of sanitation of the population-based services is where our focus is going to be. I was privileged to represent us in the Astana Declaration in Astana, which happened 2 months ago, where again we are summoning the globe to look at investing in primary health care because it is documented that return on investment is tenfold once we invest there. So investment that happened in the facility-based, if you will, level, including the equipments as you speak about, had their time because that was the approach, but also had their time because we still continue to see patients who require to be served in the facilities and have therefore made good use of the facilities which have been invested into. But a time has come now that we reorient the approach, and there is common understanding that that's how we are going to go moving forward.
Okay. Yes. I'd like to, just sticking on the issue of the equipment, is the controversy that has been, or the questions that have been around it, where counties are paying almost double the amount that they had been paying previously for the equipment that you say, well, may be needed, because we still see patients that need some of these facilities. But then when we look at the amount that is spent on it, then questions arise. And we'll answer this shortly after this break. We'll continue with Cecily Kariuki, and we still have more to answer on the issue of state of healthcare in Kenya. Stay with us.